Okay. So we're going to go first topic of the day, hypogonadism. Paul, episode number 1 of Curbsiders was hypogonadism. High time that we, almost 400 episodes later, update this. And Paul, you had some great stuff. So let's start us off here.
Sure. I will mention that since I wasn't on that episode and it was before I was part of Curbsiders, it's basically not even a real episode. But I will mention this was a great talk by Dr. Brad Annawalt at the University of Washington, who talked about the not screening for, which we'll get into, and management of hypogonadism. So the point being, he started out with, you don't screen. So this is not something that you're just sort of shotgun testing for necessarily. Like I think testosterone is checked for a lot of reasons. A lot of times because patients ask, they may be reporting symptoms of fatigue, or maybe they feel decreased attention, but these are not typical symptoms of hypogonadism. I thought this was a funny way to say it, specific, non-specific symptom of hypogonadism is actually decreased libido.
Right.
So of all of them, that's maybe the one that should maybe make you think about it. And that requires the presence of a previously intact libido. So it's if you always had a low libido, that's different than someone who had a libido that was quote unquote normal and then declined over time.
I can just see Justin suppressing multiple comments here.
I'm going to go. How do you validate what an increased libido? What's a baseline libido that we
Right
can
question.
use?
It's the Burke libido scale.
That's right.
Yet to be validated.
That's right.
So it's just a test waiting for you to design it, Dr. Burke.
I'll work on it.
So don't go shotgun testing. Have a relatively high threshold to be looking for. And then in terms of the testing, why don't I jump to that right now? Did you guys know that the CDC cares about serum T levels?
I did not know that.
So we are to be looking at, I want to find the exact words here, a validated harmonized assay, which I think is lovely. So the CDC now has a program for validation of this test. You can go to the CDC's website and look for validated labs on their site so that you're making, because we know testosterone testing can be widely variable, and I'll talk about that in just a minute. But to at least have validation within the test itself is helpful, so you can actually check to make sure that your lab is a validated, harmonized site for testosterone testing.
So like the INR for testosterone then?
Yeah, sounds like it.
I don't know that I want to.
Does that work out well? I don't know.
Yes, so we'll say yes, like the INR for testosterone testing. Other things in terms of testing. So again, we talked about this, there's a lot of day-to-day variations. So if you have this sort of marginally low level because someone checked or a patient comes to you and their testosterone's a little bit low, you must confirm this with a morning fasting sample. And the morning sample, I think I knew. I don't know that the fasting part was on my radar at all.
Yeah. It is. I think it's hard to always get the morning sample, let alone morning and fasting. But yes, that was Dr. Colburn, the great Dr. Colburn, your nemesis. My nemesis, yeah. He, of course, he said libido is the symptom you look for, and fasting. So
I mean, he sounds like he knows some stuff.
I like hearing it from you, Paul.
Yeah,
I like hearing it from you.
It's better from
let's
me.
Let's remind ourselves and the audience of these great. Yes.
How big of a difference by fasting?
So glad you asked, Dr. Shu. It is between 40 to 50 nanograms per deciliter higher in fasting samples. So you can have like this marginal level if you repeat it with fasting and morning sample, because it doesn't always have to be, well, we won't get into that, but the fasting samples have less variability among them and also tend to be higher in general. So you can do sort of your initial screening test, but you must confirm with a fasting morning sample.
Like 200 tends to be like the low for a lot of different labs, right? So that's a huge difference.
It's a big difference. Yeah, that's right. And depending on your reference range, there are maybe less reputable places that have funny names like the Adonis, Virility Restoration Center, I think is one that was cited, that might have a higher reference range. So as a result, it's easier to be low. So it's better to, again, the validation makes a difference. Other stuff, he talked a lot about Klinefelters in terms of being on your radar when you're thinking about sort of hypogonadism, which is not something I thought as much about. He made the point that it is often something that is diagnosed in adolescence by our excellent pediatrics colleagues, but it may often present as infertility in men in their 20s and 30s. And these patients, if they do have Klinefelter, it's almost always have an elevated FSH and LH, and the testosterone decrease may lag behind that. So you may have a normal T at first that then declines over time. And there's a huge phenotype of Klinefelters. It's not always clearly obvious. About 50% of the time, it's undiagnosed, which I thought was a stunning number. And it matters, especially for these younger patients, because it doesn't necessarily mean there's no reproduction. 50% of men with Klinefelters have extractable sperm. So if they're interested in having children, there's still things that you can do to make sure that actually happens.
Any tips on recognizing Klinefelters? Because I have limited memory of what that is and how to recognize it.
I'm so glad you asked. There was a lot talked about the physical examination specifically and looking at testes volume, which is, I've read the reports of my endocrinology colleagues. I'm like, good for you. I don't know what that means or how you checked. It turns out, as you guys apparently have discussed on an episode that I didn't pay any attention to, there is an orchiometer that you can actually get from endocrine.org that is like this series of beads, and the reproducibility between examiners is extraordinarily high for this. Like, it's better than most physical examination things that we have. So when you're checking, so 15 cc's is the lower end of normal. So lower than that, maybe think about it. And you must measure the testes themselves and not the scrotum or the fluid around them. So you have to actually sort of pull away from the body a little bit when you're comparing to the speed. So that's something I'll work on learning at some other point.
And as a pearl to you mentioning how much the misdiagnosis in adolescence, I think if you talk to an adolescent medicine specialist, they always kind of repeat this about why it's so important to be checking testicular volume after puberty and why pediatricians, not us, but some pediatricians aren't very good at doing genitalia exams in adolescence because it's an awkward thing to do. And I imagine that contributes to why it can often be missed.
I'm so thrilled to have our med pediatrician here. And for those who are just listening and didn't watch, that was a high five in case you didn't hear it.
Which we wildly missed.
That's better.
It was a deeply depressing high five, but it was a high five nevertheless. And then I'm taking too long, so I will just, I think, end with talking about some of the reversible secondary hypogonadism causes. So things that we think about that you can actually address are things like obesity, opioids, sleep apnea, acute systemic illness. Those are all potential reversible causes. The obesity one is particularly interesting. So if you can improve testosterone with increasing your daily exercise, with weight loss, and the speaker focused specifically on waist circumference when talking to his patients, which I thought it's a little bit more satisfying probably to deal with. And then the number I thought was stunning. So in general, over the age of 65, you have this acceleration as you're in the decrease in your testosterone. If you have a BMI over 30, that also causes a decrease. It causes a drop in your testosterone as well. So he made the point that a BMI greater than 30 is the equivalent of aging 10 to 15 years in terms of testosterone loss. So obesity, a really critical thing that you can actually address to fix testosterone levels, or at least make them a little bit higher. So I thought all that stuff was super high yield.
Yeah, and the waist circumference, it is. We talked about how BMI is not the greatest marker of actual obesity, so it makes sense that would be. That would be part of it. But Paul, I wanted to ask you, because you were giving us some pearls about this in pre-recording. Do I have to check like PSA and CBC? Like, what do I have to do before I start someone on testosterone? Like, how much monitoring do I have to do? Because that seems like it could be a barrier.
Terrific questions. Yeah, and I see a lot of this stuff done in terms of even doing like screening polysomnography in the absence of sleep apnea. So the 2018 Endocrine Society has some safety guidelines about how to deal with this kind of stuff. So you should you should check a hematocrit in advance of treatment. The one thing that you worry about with actual treatment is erythrocytosis. But you would check a hematocrit 3 to 6 months after initiation of therapy and then annually thereafter. PSA testing you don't have to do unless you've already opened that door. So the PSA recommendations are the same as for eugonadal men. So if you've already started it, you keep doing it. If not, it should be a shared decision-making conversation.
Great.
But is not a requirement prior to starting therapy. And it is not necessary to screen for OSA in the absence of clinical suspicion for it, or do lipid testing or LFTs or osteoporosis screening unless there's some other reason to be doing it. So you don't have to do those things to necessarily before to start treatment. So I thought that was actually really helpful too, because usually the workup that I've seen is really time consuming and delays therapy for a long period of time as you're trying to make sure everything is perfectly safe. And I think we maybe worry a little bit too much about that, at least according to the Endocrine Society.
And talking about the erythrocytosis, so back in the day, Stuart and I talked about, we had a patient we were taking care of, his cash lack, who he kept like, he had sleep apnea and then he was on testosterone for testosterone replacement, and we were running into problems with his blood, his counts being high, and they actually did therapeutic phlebotomy for him so that he could. Because he was one of those patients that just like, he swore like he needed his testosterone replacement. He felt so much better on it, and we wanted to keep him on it. And the hematologist was actually doing therapeutic phlebotomy for this guy. Probably part of it was his CPAP wasn't getting 100% adequate. But anyway, so there's outside the box thinking. And I thought that was a pretty cool case. I know Stuart and I are very proud of that one.
I recall it being discussed before.